Welcome to video 5 in the PACES series, focusing on Station 1, Respiratory Examination. We will cover the full routine, 4 common cases, distinct sign patterns, and the 4 biggest mistakes candidates make. Examiners assess 5 key skills in Station 1. Unlike Station 3, communication and managing patient concerns are also evaluated. Be sure to be courteous and efficient during the 6-minute examination. You will have 2 minutes outside with the instruction card. It will say something like, "This 58-year-old man presents with progressive breathlessness. Please examine his respiratory system and present your findings." 6 minutes inside. Examine systematically. When the bell goes, stop, turn, present. One important practical point. The respiratory examination involves examining both the front and the back of the chest. Many candidates run out of time because they spend too long on the front and have to rush or completely omit the posterior examination. You cannot assess expansion, percussion, and auscultation properly from the front alone. The fix: be efficient on the front. Get through inspection, anterior palpation, anterior percussion, and anterior auscultation in about 3 minutes. Then ask the patient to lean forward or sit up and spend the remaining 2 minutes on the posterior chest, which is often where the most informative signs are. Start, as always, with the general approach. Introduce yourself. Gain consent. "Hello, I'm Dr. Owais. I've been asked to examine your chest today. Is that all right?" Position: patient at 45 degrees, ideally on the edge of the bed or in a chair. For the posterior examination, they will lean forward, or you will ask them to sit forward. Chest fully exposed from the waist up. For female patients, maintain dignity. Expose the minimum necessary. Hand hygiene, visibly. Now general inspection from the end of the bed. This is where the respiratory station begins, and it is rich in information. Look at the patient. Are they breathless at rest? Are they using accessory muscles, sternocleidomastoid, scalenes, intercostals, to breathe? Is there pursed lip breathing, which is a sign of airways obstruction and air trapping, classically seen in COPD? Are they leaning forward with hands on knees? The tripod position, another sign of severe airways obstruction? Look at the body habitus. A barrel chest, increased anterior-posterior diameter, suggests chronic hyperinflation from COPD. A cachexic, thin patient with visible intercostal indrawing suggests severe respiratory disease or malignancy. Look at the surroundings: oxygen mask or nasal cannulae, and at what flow rate? Nebulizer on the bedside? Peak flow meter? Sputum pot, and what color is the sputum? These contextual clues are enormously useful. A sputum pot with purulent green sputum immediately makes you think bronchiectasis or infective exacerbation. Look at the chest wall itself. Is it symmetrical? Any obvious deformity? Pectus excavatum, pectus carinatum, kyphoscoliosis. Previous thoracotomy scar? Narrate your inspection clearly. On general inspection, the patient appears breathless at rest and is using accessory muscles. There is a barrel-shaped chest. I note an oxygen mask delivering 24% oxygen. Now move to the peripheries. In hands, look at the nails. Clubbing, loss of the normal nail angle, increased curvature, is a major respiratory sign. In the respiratory context, clubbing suggests bronchogenic carcinoma, bronchiectasis, pulmonary fibrosis, lung abscess, emphysema, or mesothelioma. It does not occur in COPD or asthma. This is a crucial exam pearl. If you find clubbing in a respiratory patient, you immediately shift your differential away from simple airways disease. Nicotine staining on the fingers, brown discoloration of the index and middle fingers, tells you about smoking history. Fine tremor of the outstretched hands suggests CO2 retention. A flapping tremor, also called asterixis, is a sign of severe CO2 narcosis. Ask the patient to hold both arms outstretched, with wrists extended, and hold for 15 seconds. Peripheral cyanosis at the fingertips. Wrist, check the radial pulse, rate and character. Bounding pulse suggests CO2 retention. Also feel for the respiratory rate at the wrist. Count it without telling the patient. A rate above 20 is tachypneic. Face. Look at the lips and tongue for central cyanosis. Look at the eyes. Horner syndrome, ptosis, meiosis, anhidrosis can indicate an apical lung tumor compressing the cervical sympathetic chain. This is a Pancoast tumor. Look for the plethoric moon face of steroid use, suggesting a patient on long-term steroids for respiratory disease. Neck. Palpate the trachea. This is a critical step, and one that many candidates forget. Stand in front of the patient. Place your index finger in the sternal notch and feel which side the trachea sits on. Normal. Midline. Deviation toward the same side as a dull percussion note suggests collapse or fibrosis pulling the trachea toward the lesion. Deviation away from a dull note suggests a large pleural effusion or tension pneumothorax pushing the trachea away. Check the JVP if raised, suggests cor pulmonale from chronic lung disease. Check for cervical lymphadenopathy. Enlarged nodes in a respiratory patient suggest malignancy or sarcoidosis. Palpation of the anterior chest has two key components: expansion and tactile vocal fremitus. Chest expansion. Place both hands symmetrically on the anterior chest with thumbs meeting in the midline, fingers spread around the lower ribs. Ask the patient to take a deep breath. Your thumbs should separate equally. Normal expansion is at least 5 centimeters of thumb separation. Reduced expansion on one side, or bilaterally, is significant. Unilateral reduced expansion. The side with reduced expansion is the affected side. This occurs in any condition that stiffens or deflates one lung. Effusion, collapse, consolidation, fibrosis, pneumothorax. Bilateral reduced expansion suggests a diffuse process, COPD, bilateral fibrosis, severe asthma. Tactile vocal fremitus. Place the flat of your hand or the ulnar border on the chest. Ask the patient to say 99. Feel for the vibration transmitted through the chest wall. Normal. You feel a gentle vibration. Increased fremitus. The underlying lung is consolidated. Solid lung transmits sound better than air. Consolidation. Decreased fremitus. Something is blocking transmission. Fluid, pleural effusion, or air, pneumothorax, between the lung and the chest wall attenuates the vibration. Also decreased in COPD, where hyperinflation reduces transmission. Percussion is the step that most differentiates a well-trained candidate from a poorly trained one. Do it properly. Technique is important. Place the middle finger of your non-dominant hand firmly on the chest wall. Press the middle phalanx flat against the skin. Strike the middle phalanx sharply with the tip of the middle finger of your dominant hand. The striking finger should be perpendicular to the pleximeter finger. The movement comes from the wrist, not the elbow or shoulder. Strike once or twice and move on. Always compare sides, left and right, at the same level. Work systematically. Both clavicles for apices, then second intercostal space, fourth intercostal space, then the bases, both anteriorly and posteriorly. What you are listening and feeling for. Resonant note are normal, the hollow, drum-like sound of air-filled lung. Dull note indicates solid or fluid replacing air. Consolidation gives a stony dull note. Pleural effusion gives an absolutely stony dull note, the dullest note you will find anywhere in the body. Collapse also gives dullness. Stony dull, the hallmark of pleural effusion. When you percuss over a pleural effusion, the note is so flat it feels like you are percussing a solid wall. If you find a stony dull note at the base with a straight upper border, this is a pleural effusion until proven otherwise. Hyper-resonant note are more resonant than normal. The booming sound of excess air suggests pneumothorax or emphysema with bullae. For auscultation, use the diaphragm of the stethoscope. Ask the patient to breathe in and out through their mouth, slightly deeper than normal. Work systematically, the same pattern as percussion. Apex to base, comparing sides at each level. Front then back. What you are listening for: normal vesicular breath sounds, soft, rustling, like wind through leaves. Heard throughout inspiration and the first third of expiration. Bronchial breathing is harsh, tubular, loud, equal in inspiration and expiration with a pause between them. Normally heard over the trachea, heard over the lung in consolidation, where the solid lung transmits the central airway sounds to the periphery. A classic sign, and a favorite of examiners. Reduced or absent breath sounds suggests something between the stethoscope and the lung. Pleural effusion, absent breath sounds above the dull area. Pneumothorax, absent breath sounds. Severe emphysema, globally quiet breath sounds due to loss of lung tissue. Let's discuss added sounds. Wheeze is a continuous musical sound caused by airways narrowing. Polyphonic wheeze throughout the chest, COPD, or asthma. Monophonic fixed wheeze, consider a bronchial tumor obstructing a single airway. Crackles are discontinuous, non-musical. Fine crackles, high-pitched, like Velcro being separated at the lung bases, not clearing with coughing, suggest pulmonary fibrosis. Fine crackles also occur in pulmonary edema, but these typically are bibasal and associated with cardiac signs. Coarse crackles, low-pitched, bubbling, clearing with coughing, suggest secretions in the airways, bronchiectasis, LRTI. Pleural rub is a creaking, leathery sound heard in both inspiration and expiration, caused by inflamed pleural surfaces rubbing together. Suggests pleuritis, pneumonia, PE, or pleural disease. For vocal resonance, ask the patient to say 99 and listen with your stethoscope. Increased vocal resonance, louder, clearer, over consolidation. Decreased over effusion or pneumothorax. Whispering pectoriloquy, whispered sounds heard clearly through the stethoscope, a very specific sign of consolidation. One summary sentence. State what you found. Inspection findings, trachea position, expansion, percussion note, breath sounds, and added sounds. Vocal resonance, completing signs, conclusion with next steps. Here is what this sounds like for a pleural effusion. The patient appeared comfortable at rest with no signs of respiratory distress. There was no clubbing, cyanosis, or tracheal deviation. Chest expansion was reduced on the right. The trachea was central. There was a stony, dull note at the right base, extending to the midzone, with a horizontal upper border. Breath sounds were absent over the area of dullness. Vocal resonance was reduced. Above the area of dullness, I noted agophony. There was no ankle edema. These findings are consistent with a right-sided pleural effusion. I would like to complete my assessment with a chest X-ray, CT chest, and diagnostic pleural aspiration to determine the cause. That is a complete, structured, confident presentation. Practice until it takes under 2 minutes. Emphysema. This is the most common respiratory case in PACES. The patient is typically older, with a significant smoking history. They may be breathless at rest or on minimal exertion. What you will find. On inspection, you will get barrel chest, increased anterior-posterior diameter from chronic hyperinflation, pursed lip breathing, accessory muscle use, possible cyanosis, nicotine staining. The patient may be using home oxygen, cachexia in severe disease. Hands shows no clubbing. This is important. COPD does not cause clubbing. If you find clubbing in a breathless patient, think malignancy, fibrosis, or bronchiectasis instead. CO2 retention tremor, asterixis, in severe disease. Warm peripheries and bounding pulse from CO2 retention. Trachea may be central or slightly deviated if there is bullous disease. Expansion will be bilaterally reduced. The lungs are already hyperinflated and cannot expand further. Percussion. Bilaterally hyperresonant, the classic finding. The hyperinflated lungs produce a booming, drum-like note. Loss of cardiac and hepatic dullness, because the hyperinflated lungs overlie the heart and liver. Breath sound will be globally quiet, reduced air entry throughout both lungs. The loss of lung parenchyma means there is less tissue to generate breath sounds. Expiratory wheeze may be present, particularly after exercise, or with an infective exacerbation. Vocal resonance would be globally reduced. Completing signs. Ankle edema, if cor pulmonale has developed. Raised JVP. How to present. Just listen carefully. I found signs consistent with COPD. Barrel chest, no clubbing. Bilateral hyperresonance with globally reduced breath sounds and expiratory wheeze. Expansion was bilaterally reduced. These findings suggest chronic hyperinflation from obstructive airway disease, most likely COPD, given the clinical context. I would request spirometry showing an obstructive pattern, FEV1, FVC less than 0.7. Case 2. Pleural effusion. A pleural effusion is an abnormal collection of fluid in the pleural space. It is one of the most distinctive physical examination findings in medicine. The signs are clear and consistent, making it a reliable PACES case. Common causes to know for the examiner: transudates heart failure, hypoalbuminemia, nephrotic syndrome, liver cirrhosis. Exudates pneumonia, parapneumonic effusion, malignancy, particularly lung, breast, lymphoma, TBPE, mesothelioma. What you will find: on inspection, the patient may be breathless. Look for scars, previous thoracocentesis, chest drains, tracheal deviation away from the effusion in large effusions. Expansion would be reduced on the affected side. Percussion, note would be stony dull at the base with a horizontal upper border. This is the most diagnostic percussion finding in respiratory medicine. Stony dull, not just dull, but absolutely flat, like percussing a solid wall. Breath sounds will be absent over the effusion. Above the upper border of dullness, bronchial breathing may be heard, caused by the compressed atelectatic lung at the top of the effusion, transmitting central airway sounds. Vocal resonance would be absent or greatly reduced over the effusion. Agophony just above the fluid level. This is a beautiful, distinctive sign worth demonstrating. I found a right-sided pleural effusion, stony dull note at the right base with a horizontal upper border, absent breath sounds over the area, reduced vocal resonance, and agophony above the fluid level. Trachea was deviated to the left, suggesting a large effusion. I would like to confirm with a chest X-ray and arrange diagnostic pleural aspiration. Exudative causes including malignancy would be my primary concern in this clinical context. Case 3. Pulmonary fibrosis, interstitial lung disease. Pulmonary fibrosis is scarring of the lung parenchyma, leading to progressive restriction. The most common form in PACES is idiopathic pulmonary fibrosis, IPF. Other causes to know: connective tissue diseases, rheumatoid arthritis, systemic sclerosis, SLE, drug-induced fibrosis from amiodarone, methotrexate, nitrofurantoin, and occupational exposure to asbestos. Always look for signs of the underlying cause: rheumatoid hands, systemic sclerosis changes, tight skin, telangiectasia, or ask if relevant. What you will find: on inspection, the patient appears breathless. Cyanosis may be present. No barrel chest. Unlike COPD, the lungs in fibrosis are restricted, not hyperinflated. Look for evidence of systemic disease: hands, clubbing, present in IPF and asbestosis. This is a major differentiator from COPD. If you find clubbing in a breathless patient with bibasal signs, think fibrosis strongly. Cyanosis at the fingertips. Check for rheumatoid changes or systemic sclerosis. Trachea would be central. Expansion, bilaterally reduced, restrictive pattern. Percussion may be dull at the bases, but the percussion note is not as dramatically abnormal as in effusion. Often the percussion note is reduced, but the auscultation findings are more striking. Breath sounds would be fine inspiratory crackles at the bases, bilaterally. This is the hallmark. Fine crackles. High-pitched, like Velcro or cellophane, heard in inspiration, not clearing with coughing. As the disease progresses, the crackles extend higher up the lung fields. Vocal resonance may be slightly increased over areas of fibrosis, though this is less consistent than in consolidation. Completing signs: check oxygen saturation, often low. Look for signs of the underlying cause. Check for cor pulmonale in advanced disease. How to present. Listen. I found bilateral fine inspiratory crackles at the lung bases, extending to the midzones. There was clubbing bilaterally. Expansion was bilaterally reduced. Percussion note was slightly reduced at the bases. These findings are consistent with pulmonary fibrosis. I would like spirometry, expecting a restrictive pattern with reduced FVC and TLC and a high-resolution CT chest to confirm the pattern of fibrosis. Case 4. Consolidation, the solid, airless lung of pneumonia. In consolidation, the alveoli are filled with inflammatory exudate rather than air. This produces a characteristic and distinctive set of physical signs, because solid lung transmits sound differently from air-filled lung. Common causes: bacterial pneumonia, Streptococcus pneumonia, most common. Atypical organisms: Mycoplasma, Legionella, aspiration pneumonia, post-obstructive consolidation, behind a tumor. What you will find: on inspection, the patient appears unwell, possibly febrile. They may be breathless and tachypnoic. Pleuritic chest pain may affect their breathing. Look for signs of systemic infection. Hands: no clubbing in acute pneumonia. Peripheral cyanosis, if severely hypoxemic. Trachea: central if consolidation is lobar, or deviated toward the affected side in collapsed consolidation, as the collapsed lobe pulls the trachea. Expansion: reduced on the affected side. Percussion: Note would be dull over the area of consolidation, not as stony dull as an effusion, but clearly dull compared to the opposite side. Breath sounds, bronchial breathing over the consolidation. This is the most distinctive sign. Harsh, tubular, equal in inspiration and expiration, with a pause between them. Heard clearly over consolidated lung. There may be coarse crackles adjacent to the consolidation. Vocal resonance, increased over the consolidation. The solid lung transmits voice, sounds better. Whispering pectoriloquy, ask the patient to whisper 1, 2, 3. You will hear it clearly through the stethoscope over consolidated lung. This is a specific and impressive sign. Pleural rub may be present if there is associated pleuritis, a creaking, leathery sound in both inspiration and expiration. How to present? Listen carefully. I found signs of right lower lobe consolidation, dull percussion note at the right base, bronchial breathing in the same area, increased vocal resonance with whispering pectoriloquy. The trachea was central. These findings are consistent with consolidation, most likely pneumonia. I would confirm with a chest X-ray and request sputum culture, full blood count, and CRP. I would want to calculate a CURB 65 score to assess severity and guide management. This quick reference table summarizes the key signs for COPD, pleural effusion, pulmonary fibrosis, and consolidation across clubbing, trachea, expansion, percussion, breath sounds, and vocal resonance. The 4 biggest mistakes are missing key signs, not linking signs to a diagnosis, not knowing the full sign pattern, and performing a disordered examination, especially skipping the posterior chest. Remember the golden rule. Always percuss the axilla, check vocal resonance, and examine the posterior chest. To practice effectively, time your full routine daily, listen to lung sound recordings repeatedly, and examine real respiratory patients. Critically, know the causes and investigations for common conditions, like Light's criteria for pleural fluid and spirometry patterns. In summary, follow the routine and presentation structure. Avoid the common mistakes, particularly skipping percussion, vocal resonance, and the posterior chest. Join us for video 6, where we will cover the Station 1 abdominal examination.